Let's talk about warfarin reversal. We have three options: vitamin K, fresh frozen plasma, and prothrombin complex concentrate. What is the difference? The first one is helping your body to make the clotting factors, restoring. But FFP and PCC provide the factors, replacing. Until the patient makes the clotting factors their own, we need to give some to stop their bleeding. That's what it is. Keep in mind, vitamin K is the only effective antidote for long-term management. It works slowly. Therefore, we need FFP or PCC for emergency use. Warfarin is one of the lethal side effect causing drugs you are going to prescribe. So be really careful with your clinical judgment, okay? Here, can we use these drugs alone? Let's look at it. In the liver, vitamin K is essential for synthesizing clotting factors 2, 7, 9 and 10. Hepatocyte enzyme epoxide reductase is essential for vitamin K activation. Warfarin inhibits this enzyme. This lowers the production of these clotting factors. If there is an overdose or if we need to reverse warfarin effect, we just have to give high dose of vitamin K in the form of IV. It must be slow infusion. This is to avoid anaphylactoid reactions. This adverse effect is rare but serious, so important to know. Urgent reversal is indications during acute bleeding like GI bleeding or brain hemorrhage, or when a patient taking warfarin needed an emergency surgery, maybe after an accident or especially in elderly if they break a bone or something like that. Prothrombin complex concentrate is our best available choice. It has highly purified coagulation factors, about 25 times higher than plasma concentration. Acts really fast within minutes, like effective within about 15 minutes. Fresh frozen plasma is the liquid portion of the whole blood. This was commonly used until recently. This is fresh frozen plasma, frozen. You need to thaw. This takes some time, takes at least an hour to get thawed. About 90% of frozen plasma is water, so it needs high volume, big load. Also need long infusion time. Evidence-based medical reports showing prothrombin complex concentrate is far superior than fresh frozen plasma. It has reduced risk of volume overload, faster reversal and comes with clotting factors. Even though it has clotting factors in it, PCC has a lower clotting risk compared to frozen plasma because it comes with a small amount of heparin and protein C and S. PCC has a short half-life. For instance, according to FDA drug insert, factor 7 starts wearing off within 4 to 5 hours of administration. When PCC wears off, to avoid rebound bleeding, warfarin reversal requires IV vitamin K. It is to sustain the reversal achieved by PCC or FFP. So, we must add vitamin K. That's a main point. In summary, IV vitamin K takes about 12 hours to reverse. Oral vitamin K is about 24 hours to reverse. For immediate results, you need to add PCC or FFP. Can you use PCC and FFP together? No. This will increase the risk of thrombosis. Can you use activated charcoal? Only if the patient is present within an hour of ingestion. Recommendation is it can be considered in patients who are awake and alert. Let's look at some of the questions. What is the mechanism of action of warfarin? It inhibits. Pause and answer, okay? Let me answer this. Keep in mind, warfarin will not increase or decrease the absorption or excretion of vitamin K. but it inhibits the activation of vitamin K by enzyme epoxide reductase, thus inhibits vitamin K mediated clotting factors. Then the next question is, what are the vitamin K dependent clotting factors? Pass and answer. The factors are 2, 7, 9 and 10. Okay, so that's a long list. How are you going to remember this? Here is a mnemonic. 2 plus 7 is 9, not 10. That means clotting factors 2, 7, 9 and 10. See, it's easy. The next one is, how does high dose vitamin K reverse warfarin effect? Pass and answer. Okay, let me answer. Vitamin K cannot ionically binds and inactivates warfarin. Remember, protamine neutralizes heparin-induced anticoagulation. Protamine is positively charged and heparin was negatively charged. Therefore, ionically binds and neutralizes it. Not warfarin. Protamine is another antidote, so that's a different story. And what about another point, the B and C, vitamin K will not affect warfarin's elimination or decreasing the metabolism, but they synthesize new clotting factors. That's the answer. Okay. The next question, it's a non-urgent case. A patient on warfarin needs prolonged warfarin effect reversal. His INR is 5. The best option for him is, okay, as you know, INR tells you how quickly your blood clots. That means normal number 1. So if I am healthy without any clotting issues, and I'm not taking warfarin, my INR is 1. And if the patient taking warfarin, the blood clot take about 2 to 3 times more, right? So the warfarin number will be 2, INR is 2 to 3. INR goal for a patient is, that is the patients who takes warfarin, is usually to keep between 2 and 3. There is a close relationship between INR and risk of bleeding. That's the point here. Bleeding risk increases with the increase in INR. Pause and answer this. Okay, let me answer. So let's answer the last one. Okay, idarucizumab. So anticoagulant effect of dabigatran can be reversed by the antidote idarucizumab, not warfarin. So that's gone. Then about the first one, can you withhold the warfarin dose? Okay, so let's look at it. If the patient's INR is mildly elevated, we can withhold doses of warfarin to reduce INR. Can you give PCC here, prothrombin complex concentrate? No, there is no emergency situation here, no life-threatening bleeding in this patient. So PCC is also super expensive. Each time you may end up in spending $3,000 to $5,000. We don't want to do that. So if this is if it is above 4.5, the patient has INR 5 here, we can add oral low dose vitamin K. Okay. So next case is an urgent one. The patient on warfarin needs emergency surgery. For warfarin effect reversal, you should do what? Pause and answer. Okay, let me answer this now. Okay, the first choice, you cannot wait if it is a life-threatening condition, okay, or emergency. So that is not the answer. The second one, you cannot depend on vitamin K only. It takes about 12 to 24 hours to reverse. Remember that? That's tomorrow. No, we need it today, now. So therefore, that's not the answer. What about subcutaneous? Let's talk about that. Sub-Q vitamin K is not reliable. Keep in mind, vitamin K is in 4 forms: intramuscular, subcutaneous, IV and oral. But IM and SC are with unpredictable efficacy. So we don't want to take a risk during an emergency situation. Both IV and PO shown equal efficacy. Therefore, we are going to depend on those. But they differs the onset of action. Therefore, we are going to stick with the IV vitamin K. So PCC and IV vitamin K, that's the answer. Okay. If you are a medical student, you can stay because you need this. Okay. The next case. A 70-year-old female at the emergency department with a bruising. She takes Warfarin for atrial fibrillation. She has recently begun taking trimethoprim sulfamethoxazole. Her INR is 8.5. Which of the following would be beneficial to her? Okay. Pause and answer. Okay. This is a drug interaction question. We already discussed about IM. Remember, subcutaneous, unpredictable absorption. So we ruled out that. IM, also unpredictable absorption, but another risk is risk of hematoma is reported with IM. So we don't want to use that. So there is only options IV and PO. Okay, so the A is not the answer. So let's look at the answer C and D. INR is high, 8.5. So can you use either of that, fresh frozen plasma or prothrombin complex concentrate? Still, there is no life-threatening bleeding in this patient. Okay, so don't even think about that in this case. Okay, recommendation is withheld a dose of warfarin, 1 or 2, it depends, and add low dose of oral vitamin K. Okay, that will be the answer. Okay, but let's talk about the drug interaction, about the warfarin and trimethoprim sulfamethoxazole story. Okay, you know it is an antibiotic. So trimethoprim sulfamethoxazole, the drug kills many colon bacteria. As a result, normal vitamin K absorption will be disturbed because of the gut flora. It cannot absorb from the gut. Okay, fair enough. But that is not the big thing here. The drug interaction, CYP interaction is the big thing. Keep in mind, warfarin is metabolized by a lot of cytochrome P450 systems, CYP enzymes. But out of that, the major one is CYP2C9. Patients are in clotting risk if they combine warfarin with any of the CYP2C9 inducers like rifampin. But the risk of bleeding will be high if the patient combine warfarin with the 2C9 inhibitors. Keep in mind, very important factors. Warfarin is supposed to metabolized by CYP2C9. If a drug inhibits 2C9, warfarin will be accumulating. Dose increase causes increased in INR and higher risk of bleeding. This is a huge thing. Board like to ask all these questions. Okay, it's very important to understand also. Trimethoprim sulfamethoxazole is one of the major antibiotics, especially if warfarin treated patients get an UTI. Ketoconazole, another drug it's listed, it's also important one with the CYP interaction. But nowadays, nobody prescribe the systemic ketoconazole, except like sometimes in Cushing syndrome, that's also a levo form, right? Levoketoconazole. Okay. Anyway, you can get the question ketoconazole, but commonly asked question is nowadays the major and commonly used antifungal agent and a warfarin drug interaction is with a warfarin with a voriconazole and fluconazole. It can be voriconazole or fluconazole. I want you to remember that also. That also can cause bleeding and shoot up the INR. Okay. So the next question, continuation of this one, the same patient. Okay, her INR was 8.5. Remember. So Although the patient is asymptomatic, you administered vitamin K. What dose and route of administration should be used? That's a question. Okay. So, pass and answer. The question is it IV or oral? Of course, we are going to still use oral. Okay. Low dose vitamin K is effective to treat these patients. Okay. So one point to remember is the minimum dose available is 5 milligram. It is very hard to break and the correct amount. So that's the reason for smaller doses it is convenient and accurate to mix IV dose in a fluid and make the patient to drink. It's common in the clinic. Reason, both IV and oral have similar efficacy. That's a major reason. Okay, so that's a reason. The answer is also the last. There are two answers in this list. Okay, and the last question. A 50-year-old male with a mechanical mitral valve presents with minor nose bleeding. His INR is 15.2. That is super high, right? He is otherwise stable. Otherwise stable. The nose bleeding resolves quickly with a direct pressure. No other evidence of bleeding. Okay, will you use vitamin K? If so, how, and talk about that. Okay, so in this one, this is actually a supratherapeutic INR case. Okay, so always refer the guidelines. Here you cannot just withhold the warfarin. It won't work. It is too high. Okay, spontaneous bleeding risk is very high in INR 10 and above. That is the major point here. Recommendation is patients with INR 9 or above, with 9 and above, with no significant, sometimes it will be 9 or 10, but recommendation varies. That's why I asked you to refer that. With no significant bleeding signs, oral 2.5 to 5 milligram is oral vitamin K is recommended. Okay, that is an important point to remember. INR will return to normal within about 24 hours. That's a good thing, right? But that's not the point in this question. The point of this case is, why can't you use IV vitamin K here? Because look at that. INR is 15.2. It's pretty high. Of course, there is no life-threatening bleeding here. That's right, right? So, what is the major point in this one? So, real IV vitamin K can overshoot if you are using vitamin K in this always, right? It's hard to regulate. We don't need an unwanted clot. IV dosing has to be carefully done. You may keep blocking the anticoagulant way too long. That increases the risk of clotting. We don't want that. So stick with the recommendation. For saving a life during an active bleeding situations or emergency in that case, or if needed a surgery or something, use IV vitamin K. Okay, so stick with the recommendation. And yeah, I think most of them. In summary, if the patient has an active bleeding, hold warfarin and give IV vitamin K. This is to restore clotting factors. Here is a mnemonic to help you. If the bleeding is life-threatening, do the same and add prothrombin complex concentrate or fresh frozen plasma. This is to replace clotting factors. An asymptomatic warfarin treated patient, hold warfarin and add low dose vitamin K. Hope this is really explanatory. Okay, and yeah, hope this helps. All the best for your exam. Okay.